Huh? Cyanosis. Cyanosis. If it's central cyanosis, what's that telling you? Your patient is probably?
Hypoxemia.
Hypoxemic. It's a peripheral cyanosis. What's that telling you? Are they hypoxemic?
No.
No.
Perfusion.
Okay, you got poor perfusion. So there's something wrong with the cardiac output. It's not getting to the cells. All right. So how do the tissues use oxygen? I think I don't know. I don't think I have any blanks on this part, do I? All right. So our cells undergo aerobic metabolism. What does that mean? With oxygen. They need oxygen to create energy. We create energy from the foods we eat. We break down carbs into glucose, we break down fats, we break down proteins, but mostly it's how do the cells use energy? Well, when we use oxygen, oxygen helps with that aerobic process of creating energy, and ATP is created, okay? And cells use ATP, again, for energy. All right? Now, what happens if we use anaerobic metabolism? Does that provide energy?
No.
Well, it does.
It's a little bit.
It does. But it doesn't provide the amount of energy that aerobic does, and it comes at a cost. What happens when you're exercising, guys, and you start feeling the pain or the burn? What's going on?
Slow down.
It's what?
You're tired.
You're getting tired, and the pain comes from you're starting to produce lactic acid, okay? About this time, I produce it in 5 minutes because I am like out of shape right now. All right, so if you push your cells to the point that they start utilizing anaerobic ways to make energy, you're going to produce lactate. A certain amount of lactate is normal, but you start producing large amounts of lactate, your body gets very acidotic. How do you get rid of acid? You start breathing like crazy, okay? Deep breaths, trying to get rid of the excess acid your body's trying to produce. Okay, so why would we put somebody on oxygen? Give it a shot. Why? You go into a room, oh my God, I think this patient needs oxygen. You said cyanosis, okay? Can't breathe. Okay, so they're a little short of breath. Have you done a blood gas or used a pulse oximeter to check their oxygen saturation?
Yes.
No. In this case, you just suspect.
Oh. Well,
You suspect, okay? That's all right. You don't have a pulse ox on you. You haven't got time for a blood gas. So one of the indications is to correct suspected hypoxemia. So based on how this patient looks, ooh, geez, let's get his oxygen level up, okay? So to correct suspected. Now, if you have done a blood gas, or you have a little pulse oximeter that you can put on your finger, that's what we call documented hypoxemia. So you're going to correct documented hypoxemia, okay? Documented hypoxemia is a PaO2 less than 60 millimeters of mercury and an SaO2 of less than 90%. You may not know what those mean now, but you eventually will. This is a memorization thing right now, okay?
What's that, like partial pressure?
That is the partial pressure of oxygen in the artery. You have had to have done an arterial blood gas, which you will all learn how to do, okay, in order to document hypoxemia. Any PaO2 less than 60 millimeters of mercury, right now normal PaO2 is 80 to 100. So this would be documented hypoxemia. Your saturation, the saturation of your arterial blood right now, is most likely 95% or higher. If it drops less than 90%, you have hypoxemia. That's documented. In other words, you've done a lab test. If you suspect hypoxemia, this is an acute care situation, so this is an emergency. You suspect hypoxemia, get them on some oxygen, okay? You suspect it, you're not so sure, but get them on. It's not going to hurt them. If anybody comes into the trauma room suffered some kind of trauma, or they come in with a suspected myocardial infarction, they're going to go on oxygen, okay? So, if you have severe trauma or an acute MI, you go on oxygen. We'll talk about why in a few minutes. And then, many times, it's used post-operatively. You've had an OR procedure, they take out the breathing tube.
MI is that mild stroke? Or
Myocardial infarction.
Okay.
Yeah, MI is a myocardial infarction. Okay. And that is how it would be written in the chart. Okay. The other point is we might give it post-operatively. You wake up, they pull out a breathing tube, they put you on a little bit of oxygen. So it might be used short-term therapy post-op. Okay. These are the indications for oxygen therapy based on the American Association for Respiratory Care. So this is why this is indicated. If, or let's say when you read the chapter in the book prior to class, right?
Yeah.
Yes.
If you're looking away from me, you didn't read the chapter. Now, if you look in your book, this follows the book. If you need to fill out your objectives, you open Egan, okay? This lecture follows the book. So these are your indications. Now, what are the goals? So if this is the indication, what's the goal?
To give them a proper amount of oxygen.
Okay, so you want to correct documented hypoxemia, okay? You want to also relieve the symptoms of chronic hypoxemia. Those would be a COPD patient. So number one, you want to correct acute. What does acute mean?
That is
Happening right then and there. A serious, an emergency situation, you've got to fix it. So you want to correct that. Here, decrease the symptoms. Okay, what's associated when you're hypoxemic, what happens to the patient? Okay, what symptoms do you see? You want to correct that. The other thing you want to do, and this adds to the acute MI or severe trauma, okay, you want to decrease the workload that hypoxemia puts on the cardiopulmonary system, okay? So when you're hypoxemic, you're going to be short of breath. Your heart's going to work harder in order to try and get oxygen to the tissues. Does that make sense? Okay, so the indications are different than the goals. 5 indications, 3 major goals. Okay, so how does oxygen correct documented hypoxemia? Again, when we start talking more in 1570, you'll understand more about this, but when you inhale more oxygen, what happens to the oxygen in the alveoli? Oxygen level in your alveoli right now is about 100. Okay, so if I put you on 100% oxygen, what's going to happen to that alveolar PO2? It's going to go way up. Okay, so if you have a PaO2 of 60, an arterial oxygen level of 60, and I put you on more oxygen, it's going to increase the oxygen in the alveoli. Where does it go from the alveoli?
the capillaries.
It has to get to the capillary. How does it get to the capillary? What does it have to go through to get to the capillary?
The alveolar, the interstitial space.
Well, where does it go through first? So it's sitting in the alveoli. Then what does it first have to diffuse through?
The fluid lining.
Think about all the fluid lining in the alveoli. Then what does it go through?
Type 1.
Type 1 epithelial cells, the squamous cells. Okay. Then it has to. This is the oxygen that's diffusing. Then where does it go?
Interstitial space.
Interstitial space, and then from the interstitial space it goes to
The membrane, the capillary membrane. No.
the capillary membrane. What do we call a vessel membrane? Epithelial or endothelial? And finally, it makes its way into the plasma, and then it has to go to the red blood cell. So it has to go through that space. So if anything makes that space wider, it's not going to make it through, is it? Right? Okay, so it corrects documented hypoxemia by doing what? By increasing the alveolar. You have to watch this. Big A is alveolar, little a is arterial. Okay? So it increases the alveolar PO2 and eventually raises the oxygen of the artery. Okay?
You said the big A is alveolar.
Big A is alveolar. That is the partial pressure of oxygen in the alveoli. The little a is the partial pressure of the oxygen in the artery, which comes from the capillary, goes to the arterioles. Eventually, it moves its way into the pulmonary veins, out the aorta, and to the rest of the body. Does that make sense?
So does the lowercase and uppercase matter?
Yes, absolutely. Because uppercase A means alveoli and lowercase a means arterial. And that's going to become critically important in 1570 when you start doing calculations. Okay?
Arterial,
So big A is always referring to alveolar. And little a always refers to arterial. So you want to increase alveolar oxygen so that that extra oxygen can diffuse across the AC membrane, get into the capillary, and eventually move out to the arteries and into the capillaries for the tissues. Does that make sense? Everybody? Make sense? Okay. All right. Documented hypoxemia. How do we document hypoxemia? Well, we can do it invasively with an arterial blood gas. Okay, you will learn how to do that, okay, sticking the artery. And from that blood gas, we can get a measure of arterial oxygen, and we can also get a measure of how much oxygen is saturating the hemoglobin. Now, did anybody ever go to the doctor and they stick something on your finger and they wait for it to read your oxygen level and your pulse? Okay, well that's what it's actually doing. When they stick this thing on your finger that has a red light in it, it's measuring your oxygen saturation and your heart rate. That is called, whoops.
Is that accurate?
Huh?
Is that accurate?
Yes, it is. If it's accurate, if you have good perfusion, and if you were to do a pulse check, if your pulse check is matching what the pulse rate is on the little stand there that you're working with the pulse oximeter, yes, then it's accurate. But if the pulse rates don't match, or if the heart rate is irregular, if the patient's in atrial fibrillation, it may not correlate. Okay, but you've got to have a strong pulse, and the heart rates have to match on the pulse oximeter and when it's checked by feel. Okay, so invasive or non-invasive? Invasive is an ABG, and the ABG gives you the SaO2 and the PaO2. That is the saturation of oxygen in the artery, or the partial pressure of oxygen in the artery, or non-invasively with a pulse ox. And the reading you get for that is called S_p_O2. It's not up here, okay? With pulse oximetry, you're getting the saturation PO2 with a pulse ox. That's what that means, okay? So, I don't have any of these markers. Okay, so with an arterial blood gas, where it goes down to the lab, you draw blood from somebody's artery, usually in the wrist, okay, or you can do it in the brachial artery. You draw blood, it gets sent down to a lab, and you'll get the P_AO2, the partial pressure of oxygen in the artery, the S_AO2, that's the saturation of the hemoglobin. If you choose to just do pulse oximetry, where it goes on your finger with a little light, that's going to give you the capital S, small PO2, the saturation of oxygen. It's a way for us to say, okay, without doing a blood gas, which costs about $250, it could be even more, $250 at this point to do a blood gas, you can just do pulse oximetry and say, okay, I need to put this patient on oxygen if you have a good correlation between your heart rate and what the pulse ox is saying. Okay? There are some pulse oxes, Eileen, you're asking me, do you do pulse ox checks?
Yes.
There are some pulse oxes that give you a waveform. You have a nice, strong pleth, they call it. You can say that's accurate. So if you ever wonder about the accuracy, do a pulse check, counting with your fingers, and see whether it's matching at the same time you're checking the pulse ox. Have your fingers on the pulse and just feel, am I seeing the little lights go up and down at the same time? But if the patient has an irregular rhythm, it's most likely not going to be accurate, okay? Okay, so how does supplemental oxygen decrease symptoms of chronic? When we say chronic hypoxemia, that is somebody, this is not an acute care situation. COPDers run with a PaO2, P little AO2, of about 55 to 65. That's hypoxemia, okay? They run with that. If they become more hypoxemic, they start breathing. How do you think they breathe? Hypoxemia. Your oxygen level drops. Would they be tachypnic? Yeah. You think they'd be dyspneic?
Yeah.
What's the difference between dyspnea and tachypnea?
Tachypnea is fast respiratory rate.
Tachypnea is fast respiratory rate. Is it objective or subjective?
Subject. No, objective.
Tachypnea is objective. It is a respiratory rate higher than 20. Tachypnea is something that you are measuring. Can you measure dyspnea?
No.
No. Dyspnea is what? Subjective, and what's the definition? Because sometimes people still aren't getting that right. What's the definition?
That's perceived.
Yes, it is shortness of breath or difficulty breathing as perceived by the patient. That's a subjective finding. Okay, they may be tachypnic, but they're telling you, no, I'm not short of breath, because that's their baseline. Okay? Okay, so patients with lung disease on supplemental oxygen, they may need it because what it does is it decreases their perception of their dyspnea. Okay, it decreases dyspnea. Also, more oxygen to the brain, your mental function will increase. Okay? And our last part here, how does oxygen decrease the cardiopulmonary workload? When we say cardiopulmonary workload, what do we mean? The workload on the what? The heart and the lungs. Okay, so when we have our hypoxemic, we increase our respiratory rate and tidal volume in an effort to increase our oxygenation. So we work harder. For the cells to get more oxygen, that heart rate has to beat faster. That's one of the first signs in the cardiac side of hypoxemia, tachycardia. Okay? Blood pressure goes up, they're tachycardic. So the heart is working harder to get oxygen to the tissues. Yes, Wyatt? Oh, you look like you were going to ask me a question. Okay, so supplemental O2, what's that going to do? Decrease the work of breathing on the lungs. You get your oxygen, your respiratory rate slows down, your tidal volume gets lower, the general work of breathing goes down, and you give more oxygen, and what does the heart have to do? Does it have to work as hard? No. So the heart rate comes down, and the blood pressure comes back down. Okay? All right, so indications, the need for oxygen. Documented. No, we're going back to tachypnea. We're going back again to the indications. Why would a patient need oxygen? Number one, they have documented hypoxemia. Documented means a PaO2 what? A P little AO2, less than 60 what? Millimeters of mercury, okay? A saturation of arterial oxygen of less than 90%, so documented, okay? Suspected. You walk in a room, you think this patient is hypoxemic by all the symptoms. Get them on oxygen, okay? What else? Patient comes in with severe trauma, get them on oxygen. It's an automatic. We don't even ask. They come into the trauma room, they get popped on 100% non-rebreather mask. Okay?
Say that again, even if they don't, if they come into.
You come into a trauma area, you have a gunshot to the hip. I don't care where it is. They could be losing a lot of blood. They're going to get put on oxygen. Okay? Until we get their saturation checked and we say, oh, okay, they're high. You know, we don't really need that. Just put them on lesser amounts of oxygen. All right? Acute MI, that's huge. Everybody out with an MI gets put on oxygen. Everyone. Keep the workload down on the heart. A myocardial infarction means part of the area of the heart is dying, okay, because perfusion is blocked to a particular area. All right? And the last one is short term. Anybody that goes to the OR right after procedure, you're going to be on oxygen. Usually take it off. They check your pulse ox and say you don't need this anymore. When I say check your pulse ox, what does that mean, guys? The little thing on your finger. Okay, you'll learn more about that down the line. All right, so those are our indications. So what are our goals? To correct documented hypoxemia, right? Everybody awake? I'm just reviewing what I just sat here and spit out to you. Okay, so we're going to correct documented. We're going to decrease symptoms of chronic hypoxemia, and we're going to decrease the workload on the heart and the lungs. Okay, so when you get a question, that's what I want to see. Not something you make up. Throw some shit at me that I have no idea what you're saying. Okay? Okay. All right. Oh, by the way, okay, the second year said to me in Ocean City that the first years thought you were ultra religious and then you cursed and you're not religious. I beg your pardon. I am religious. Okay? I just let it fly sometimes. All right.
They told you that?
Yes! I said, what?
Those snitches?
Okay. So, all right. Symptoms of hypoxemia.
The other side, please.
Yeah. All right. Everybody good? Solomon?
Yeah, thank you.
Okay. All right. Symptoms for hypoxemia. Well, first, if anybody printed this out before I went back and said, well, I think I better tell them what normal levels of oxygen are. Is this on your paper?
No.
Okay, so fill this in before we get to mild to moderate to severe hypoxemia. Normal PaO2 is 80 to 100 millimeters of mercury. That's what everybody in this room should be right now. And based on how you look, I'm using my eyes to inspect how you look. Nobody's tachypnic. Everybody looks fine. So your PO2 is most likely between 80 and 100. Okay. All right. Mild hypoxemia. Just memorize these. Okay. 60 to 79 millimeters of mercury. That is mild hypoxemia. Moderate hypoxemia is 40 to 59 millimeters of mercury. Severe hypoxemia is less than 40 millimeters of mercury. Okay. So remember these when we start talking about what the respiratory, cardiac, and neurological symptoms are for somebody that is hypoxemic. The respiratory symptoms for mild to moderate hypoxemia, what did we just say was one of the things? Tachypnea. Tachypnea, dyspnea, and paleness. Pale. Your skin lacks good color, okay? Now, if you have severe hypoxemia, that means your PO2 drops below 40. You are going to be tachypnic, you're going to be dyspnic, but you're going to be cyanotic, okay?
How about during moderate?
Mild to moderate is the top. See,
Oh.
mild to moderate, tachypnea, dyspnea, paleness. If it drops below 40, the only difference is you're going to be cyanotic. How many grams of desaturated hemoglobin must accumulate per 100 milliliters of blood for you to show cyanosis? More than 5 grams of hemoglobin per 100 milliliters of blood that goes by. Okay? All right, has to be desaturated. All right, now cardiovascular symptoms. Mild to moderate would be, what did I just say? What happens when you're hypoxemic? What happens to the heart rate?
Go down.
It increases. You become tachycardic, okay, and you have mild hypertension. Now, if it's severe, meaning it drops to less than 40 millimeters of mercury, this is the key. You are going to have tachycardia that will evolve into a bradycardia. It means it turns into a bradycardia, and you can become asystolic, okay? Hypertension eventually evolves into hypotension. And let me tell you, it doesn't take that long. If you do not respond to your patient's moderate hypoxemia and they drop their PO2 to less than 40, you could be standing at bedside. They get, I am not kidding you, because one time when I was in the ICU and I had to suction somebody and that didn't have an airway in, so I had to go down the nose. We gave him oxygen, but he vagaled down. In other words, you can hit the vagus nerve. All right, so it wasn't hypoxemia that was causing it, but I hit the vagus nerve, and all of a sudden, he got grayish, okay? The eyes rolled back into the head, and the heart rate, 60, 40, 30. I mean, he was going down, and I just grabbed an ambu bag with 100% oxygen and bagged him, and he came back up, okay? But it can happen when you're standing there looking at somebody. You have to recognize what the problem is, okay?
Did you know at the time that you had hit the vagus nerve?
No, I thought he was hypoxemic, but he wasn't hypoxemic. He just vagaled down because he was gagging. Okay, but what brought him back was just bagging him with 100% oxygen. Okay, so severe hypoxemia, tachycardia evolving, meaning you're tachycardic and then you start dropping your heart rate. Here you're hypertensive, and all of a sudden when your heart rate goes down, your blood pressure drops because you have no cardiac output. Okay? Okay. Neurologic symptoms, if anybody's in the hospital and all of a sudden they get suddenly agitated, confused, you can't figure out what's going on, residents will say many times, get a blood gas, they want to make sure they're not hypoxemic, okay? So if you have restlessness, disorientation, headaches, and it all of a sudden came on, the thought is, are you hypoxemic, okay? If it's severe hypoxemia, what can happen here? Coma, vision is impaired. Loss of coordination, blurred vision, tunnel vision, okay? So as the hypoxemia gets worse, guys, the symptoms get worse and worse and worse. So what's normal PO2? 80 to 100. Mild? 62, 79. Moderate? 42, 59. Less than 40, severe, okay? Are these on your sheets?
Yes.
Okay. All right.
1 second, please.
Okay, so we talked about the indications, the goals, and then what happens when somebody is hypoxemic. So now, how do we monitor a patient on oxygen therapy? It needs to be done with, we assess a patient for, we look at their P-little AO2, that's done by an arterial blood gas, as we said earlier. An S-little AO2, that's also done by blood gas drawing. And the least invasive way, which is a really nice way, is pulse ox, because it just involves a matter of putting an adapter on your finger and looking at your oxygen level. So how often does the AARC, the American Association for Respiratory Care, tell us we have to monitor oxygen equipment? Once a day at least. Now, If somebody has an artificial airway in place, meaning an endotracheal tube or a tracheostomy tube, or if they're on greater than 50% oxygen, what's the most amount of oxygen we can give? 100. What are you guys breathing right now in the room?
80 to 100.
Nothing?
No, we're not.
Oh, I was going to say, I hope not, because we'll be having some symptoms of hypoxemia, okay? 21% is what you're breathing right now, okay? And for you to breathe 21% oxygen, your lungs are working fine. That gives you an alveolar PaO2 of 100. That's normal. And it gives you an arterial PO2 of 80 to 100. If something's not working right, a small area of the lung has pneumonia or has atelectasis, your oxygen levels will be negatively impacted, okay? So, artificial airways and greater than 50%, you monitor more frequently. Okay, so what are the complications? Everybody?
I'm sorry, what?
We good? Greater than 50 and artificial airways, is that where the blanks were?
Yes.
Yeah.
Okay. All right, so then you monitor more than once a day. Okay, so with every drug there's complications. All right? Oxygen toxicity can cause a boatload of problems for people. The higher the amount of oxygen we have to give somebody, the more of a risk that we're going to cause oxygen toxicity. Oxygen's a fire hazard. Would oxygen just go on fire? Is it flammable? It's not flammable, but it supports combustion. In the presence of oxygen, a fire burns brighter and hotter, okay, and it burns faster. All right, so you've got a fire hazard. You can cause physiological changes in somebody's body by giving them high amounts of oxygen for a long period of time. In babies, you can cause blindness with giving them too much oxygen. That has to be monitored. Babies, newborns, too much oxygen can cause thickening of the retina area and they end up blind, okay? So these are the problems. Ventilatory depression, meaning you slow down your breathing. Now that doesn't happen to a lot of people. It only happens in one patient population. Does anybody know what it is?
Elderly. The elderly.
No.
Yeah, me?
No, it happens in patients with COPD, and we'll talk a little more about that in a minute. Absorption atelectasis. This is when alveoli collapse because the oxygen that's in them starts to deplete out behind an obstruction, and they collapse and close up. Okay, so we'll look at each of these 5 briefly. All right, oxygen toxicity. Okay, that depends on how much oxygen you're giving and how high the PO2 is and the length of exposure to the high levels of oxygen as to whether you're going to develop these issues. So when does oxygen toxicity occur? If you are having to give somebody greater than 60% oxygen for longer than 48 hours, they are at risk for oxygen toxicity.
More than 60% during 48 hours.
Over 48 hours. I think there are some blanks on your slides. Is there some blanks? Greater than, it says, 60% for how long? 48 hours. Okay, fill that in. All right. So above 60% for greater than 48 hours. However, here's the key. No matter what, if you have to give that level of oxygen, you don't have a choice, okay? Because to not give it would deplete the cells from oxygen, and then you have a greater problem, okay? So high FiO2 should never be held from critically ill patients, but the point is try to drop them to the minimum O2 required to guarantee tissue oxygenation. And that is shooting for a PaO2 of about 60 millimeters of mercury. Okay, so whatever you have to do to get it to that point, we're going to give you oxygen to get it to that point. And if it's 100%, that's what we have to give you. Does this make sense to people? Okay, so what causes the damage? Well, the higher the PO2, the more free radicals are produced. Oxygen produces free radicals. Generally, the body can handle these free radicals running around, but if you give them more oxygen, there's more free radicals. And what do free radicals do? They cause tissue damage. They cause damage to the alveolar capillary membrane, and that's what happens. And from that point, and they cause tissue problems all throughout the body. It can end up causing multi-organ dysfunction. So, oxygen toxicity, that's a little further on down the line, what I just talked about, impacts primarily lungs and central nervous system. Okay? The CNS affects tremors, convulsions, if you're getting too much oxygen, twitching. Okay? We sometimes see that in hyperbaric chambers where we're delivering high amounts of oxygen at more than 1 atmosphere. Those can be the effects. Everybody good? In the lungs, it's those overproduction of the free radicals, and they cause alveolar capillary membrane damage. And when you have the damage, when we say damage, it means breaks and holes in the AC membrane. So then fluid just seeps right into the alveolar capillary membrane. So what happens to the surfactant when fluid seeps into the alveoli? What do you think happens?
I'm sorry, what?
What do you think happens to the surfactant when fluid leaks in the alveoli?
This surfactant is no longer it's no longer reducing the surface tension.
Yeah, why? Because it gets diluted. It's like putting too much water in your coffee. It gets diluted. Doesn't have the same kick. Okay? Too much. What happens is when these oxygen-free radicals break down the AC membrane, fluid from the blood vessels and the interstitial spaces leak into the alveoli. They become fluid-filled. Surfactant no longer works. They're either flooded and consolidated or they collapse. Okay. So, what's the magic FiO2 that we would like to stay below or at? What did I just say? If you're on greater than 60% for 48 hours, the chances of this happening increase. Okay? So, if you guys have to put somebody on 100% oxygen, everybody gets antsy in the ICU when we need 100%, and we need 100% a lot of times. So the goal is to try and get them off of 100% within the first 24 hours. Okay? Within the first 48, try and get them below 70%. And within the first 5 days, try and get them below 60%. Okay? So you got 24 hours to try and get off 100%. You got 48 to try and wean below 70%. And your hope is that you can do that so you don't cause problems with oxygen toxicity, because this stuff is sometimes irreversible. Okay? So if you don't have much surfactant in, what does that do to elasticity? Elasticity increases. Elasticity goes up, so what happens to compliance? It goes down. So what's going to happen to the pressure in order to inflate those alveoli? Much more pressure to get them increased, okay? So physiological changes are a decrease in lung compliance. Anybody want to give this a go as to what this means? What's the big A?
Alveolar.
What's the little a?
Arterial.
Okay, so if I, this is just making me crazy. So if I have So if I have my alveoli, okay, and I have a PaO2 of 100, that's great and dandy, but if my this is the capillary, so if my alveolar capillary membrane is all messed up and broken up, and I can't get that 100 in here, and down here it's 60 instead of in the capillary being 80, okay? The P big A little a O2, that is the difference between what's in the alveoli and what's in the capillary. That difference should be no more than 10 to 20 millimeters of mercury. So what happened here to that difference? 160. What happened? What's the difference here between what's in the alveoli and what's in the capillary?
40.
160. 40. So the AA difference increases. Does that make sense? That's what the P big A little AO2 is. That is the difference between the amount of oxygen in the alveoli and what is in the capillary. And if you have any problem across the AC membrane, that difference is going to go up, and that's bad. Okay? It should normally be, if your lungs are working well, there should be not much of a difference between what's in the alveoli and what's in the artery. Okay?
No more than 10 to 20. Right.
Normal is 10 to 20. You're going to be responsible for that in about 2 weeks, okay, in cardiopulmonary. So the AA difference goes up. The partial pressure difference between the oxygen in the alveoli and the artery increases. That's what that means, okay? And then, along with that, okay, your lungs, when this happens, instead of the lungs on X-ray looking like this, okay, nice and black with air on the inside, they become patchy infiltrates, means you see white stuff all the way throughout the lungs, meaning these lungs are consolidated with fluid or collapse. So that nice black area in the lung is going to look like white patches all over, telling you there's no air in there. Okay, so the findings would be a decrease in compliance, an increase in the difference between what's in the alveoli and what's in the artery, and you would also see patchy infiltrates on the X-ray. Infiltrates mean there's something in the alveoli other than air, okay? So it's on an X-ray, it's going to be shot through and looks white instead of clear with air. Any questions? Any questions? No? Okay. All right. So, avoiding oxygen toxicity, what did I just say? You have to wean off 100% within the first 24. First 24 hours, okay? All right. Try to decrease down to 70% within the first 48. The idea is to wean off down to below 60 within 5 days to try and avoid oxygen toxicity and all the effects that we just said. Destruction of the AC membrane, decrease in compliance, infiltrates on X-ray. That's all going to happen if you develop oxygen toxicity. However, never hold back oxygen from a hypoxemic patient. But it's just telling you, when the resident is on your butt, get him off of 100%, accept PO2s of this level to get him off. That's why they don't want problems developing, because we've left them on toxic levels of O2, which is anything greater than 60%. Okay? And like I said, sometimes that's impossible. All right? And you'll learn about modalities that we use in order to help us try and do that in the springtime. Okay? Okay, did everybody get these numbers? All right. Okay, so what happens in babies? You're going to learn this from Joni when you take neonatal, which is what the second years are taking right now, neonatal and pediatric respiratory care. I really don't go into this any further than to say we try and keep the blood level of oxygen in babies less than 80 millimeters of mercury, P(a)O2, because what can happen is you develop retinal scarring on high levels of oxygen, these premature babies, and they can become blind. That's about as much as I go into on this. And it's called retrolental fibroplasia is the old name, or retinopathy of prematurity, ROP. You'll learn more about that from her. Okay. All right. Everybody get that? So PaO2 less than P(a)O2 we're talking about. When we talk about blood levels, it's P(a)O2, less than 80. Okay? Depression and ventilation.
I didn't get that.
Okay? Less than 80. Okay? All right. Again, certain part of this is memorization. You'll learn more about this in the future with depression and ventilation. What makes you guys breathe? Okay, what happens is your brain senses increased levels of CO2 if you don't breathe, carbon dioxide, and it says take a breath. Okay? What happens with COPD patients is they breathe, if they are a COPD patient whose drive to breathe is not CO2, their drive to breathe is a low oxygen level, okay? And this is people with end-stage lung disease. Their drive to breathe is to have a PaO2 of 55 to 65. If you give them oxygen and increase their level to 80, they have no stimulus to breathe. So they slow down their breathing. Okay? They slow it down, and what happens is they retain more and more and more CO2 because they're slowing down their breathing. So giving oxygen to a patient with chronic obstructive pulmonary disease whose drive to breathe is a low PO2 and not a CO2 like yours, a high CO2, you will depress their drive to breathe. So we have to make sure that we don't kick up their oxygen levels higher than 65 millimeters of mercury. And this is a small population of chronic obstructive lungers. We used to think that everybody with COPD had a hypoxemic drive to breathe, but they don't. So is everybody following me? You guys have a normal PO2, 80 to 100. Your drive to breathe, your brain responds, your chemoreceptors respond to high levels of CO2. So you'll yawn, or you'll kick up your respiratory rate, okay? Their drive to breathe is a low PO2. So if we give them too much oxygen and bring up their oxygen level to higher than they are used to, they will slow their ventilation down. So this is only true of a small percentage of people with chronic obstructive pulmonary disease. Their drive to breathe is a low oxygen level. This is what they're used to breathing with. If you kick up that oxygen level, they will slow down their breathing. And their CO2 levels can go up as high as 20 millimeters of mercury if we do something like that. And they will become lethargic. You haven't done them any favors. So when you're out on the floors, when you're out in the general floor care area, if you're taking care of a COPD patient, it's critical if you know how to learn, which I'm not going to go into now, as to whether this patient has a hypoxemic drive, and you have to be careful how much oxygen they get. Okay? Make sense? Okay, what's your drive to breathe? Carbon dioxide. What's their drive to breathe? Low oxygen level. Now, if it gets too low, but have it 55 to 60, okay, is 65 is what they're used to it. So if you kick up those levels, they slow down their breathing. All right. Okay. However, never withhold oxygen from a hypoxemic COPD patient. You just need to know what level of PO2 is good for them. Okay, So you remember, this is a good line, the FiO2, in other words, that's the fraction of inspired oxygen. The fraction of inspired oxygen that you're all breathing right now is what? How much oxygen are you breathing? 21. 21%. 21% oxygen right now is in the atmosphere, okay? All right, so it's not the level, it's what you're doing to their P little AO2, their arterial O2. And absorption atelectasis. Okay. So, if a bronchus becomes obstructed, does that sound familiar, Leo?
Yeah.
If a bronchus becomes obstructed, all right,
Of course.
all right. Oh, that's terrible. Right upper lobe, right middle, right lower lobe. God, if you can imagine that. Left upper lobe, left lower lobe. So now you have the takeoffs, okay, to the different segments. So let's say this becomes obstructed right here with a big old mucus plug, or you aspirate a foreign object. Okay. Now, this alveoli up here has air in it. All right? Can you get fresh oxygen into it?
No.
No. Can you empty out that alveolus?
No.
Well, how are you going to exhale? You got trapped gas in there, right? Trapped gas. Okay? So, here's your blood vessel going by. All right. Most of what's in the alveoli is nitrogen. Okay, 78% nitrogen, because that's the amount of nitrogen in the room. 78% nitrogen, 21% oxygen. And you got 21% oxygen. So what's going to happen with what's in there? It's not being refreshed. Oxygen readily diffuses into the capillary. So whatever oxygen is in there, it's going to eventually diffuse into the capillary. Nitrogen will also diffuse, okay? So what happens to the partial pressure of the gases in the alveoli?
Go down.
They go down. And what happens to the alveoli? It shrivels up. Okay? That's absorption atelectasis. Now, from an obstruction. However, if you give 100% oxygen to somebody, so this is a bronchial obstruction. So initially you're going to have air trapping with a bronchial obstruction, but then eventually it'll collapse, all right? If you give somebody 100% oxygen, what's going to happen to that 78% nitrogen? You're giving somebody 100%. Is the nitrogen going to eventually be flushed out?
Yeah.
Yes. The nitrogen's eventually going to be flushed out and you'll have alveolar collapse again due to nitrogen washout. Okay? So the most plentiful gas in the alveoli is nitrogen. 78%. FiO2s greater than 50% lead to rapid absorption atelectasis. Absorption meaning the nitrogen got absorbed into the bloodstream. Okay? So the partial pressure in the alveoli drops and the total gas pressure goes down until the alveolus collapses because the oxygen will also diffuse out. So anytime you have a bronchial obstruction, the nitrogen and the oxygen are going to diffuse out and the alveoli will eventually collapse. But if you give somebody 100% oxygen, you're going to flush all the nitrogen out and you'll still create alveolar instability and they will collapse because the partial pressure drops significantly within the alveoli.
What's the time The time frame that we're looking at between the time that it becomes obstructed and it is inflated at first and then it collapses.
Okay, so that I can't tell you.
It varies.
Okay, so, but the point is we try and get off 100% for oxygen toxicity within a very rapid amount of time, within the first 24 hours. So how fast absorption atelectasis occurs? Probably within that 24-hour period that can occur. Okay, but at the same time, like when we're giving somebody 100% oxygen, we're trying to get off the 100%, so we're using special modalities to try and pop those alveoli open. Again, I'm not going to tell you about that now because it's more than you need to know right now. Okay.
So
Yes, Aleke.
Nitrogen has nothing here for breathing, but oxygen is. So how
Nitrogen what?
Nitrogen does not nothing for breathing, right? Just we.
It keeps the alveoli open.
Open, okay.
Yeah, it keeps the alveoli open because most of the air that you're breathing in the room is nitrogen right now. Only a small percentage is oxygen.
Yeah.
So the partial pressure of the alveoli still has to be a total of 760 or it will collapse. Okay? Okay. All right. So the risk of absorption atelectasis is greatest in hypoventilated lung units, like right here. If the alveolar region is obstructed, if an airway is obstructed, and there's no source of fresh gases, total gas pressure will drop. And that's what I just drew. If you had a big old mucus plug or aspirated a foreign object that they couldn't get out of there, eventually your alveoli that lead from that takeoff will collapse. All right? And patients breathing at small lung volumes. So when would you breathe at small lung volumes? Overinflated, you may breathe at small lung volumes. We're looking more as to, is there a problem within your suppressing your drive to breathe? So what could suppress your drive to breathe? Sedation, pain. If you have an abdominal wound, you're going to breathe rapidly but small tidal volumes. Or if you have some abnormality in the brain, okay, in the brain stem, which is in charge of your breathing, okay? Then your breathing, you may breathe rapidly but very tiny tidal volumes. So what happens in those areas, all right, you lose your oxygen faster than can be replaced because you're breathing at very small volumes. So you can't refresh that FRC as easily as if you're taking nice breaths in and out. Good? Okay, and our last one, fire hazard. Please don't say that oxygen is flammable. It is not flammable. It supports combustion. So in other words, if there is a fire and there's oxygen around, added oxygen, like the oxygen is turned on in the room, okay, that fire is going to burn hotter, faster, brighter. All right, so let's just